So let us talk about breast MRI in short. Breast MRI is important because it is highly sensitive for detecting invasive breast cancer. It is the technique of choice for assessing the integrity of breast implants. The breast MRI technique requires a minimum 1.5 Tesla machine, dedicated breast coil, breast compression, prone position of the patient with the breast hanging down into the coil. Gadolinium based contrast agent is necessary. Fat suppression technique is necessary, that may be active, may be passive. In case of active fat suppression, parallel imaging sequence has good spatial and temporal resolution. There are many passive fat suppression technique too. Among the passive subtraction technique is faster. It has also good spatial and temporal resolution. And then why we need fast 3D gradient echo MRI pulse sequence, because it is the optimum method for small lesion detection, and faster MRI sequences are necessary to obtain faster or better temporal resolution, and better temporal resolution is necessary in breast imaging, because when we administer gadolinium administration, the we can differentiate between malignant and normal lesion within first 2 minutes. Again, temporal resolution is necessary to characterize a malignant lesion. As we know that malignant lesion has a property of rapid contrast and uptake and washout. These characteristics can be captured by MRI. If we acquire dynamic MRI every minute over a period of 6 to 7 minutes after the gadolinium injection. So but we have to keep in mind that more the temporal resolution, less the spatial resolution. Why 3 Tesla machine is required in breast MRI? 3 Tesla machine can give more signal to noise ratio, but field inhomogeneity can lead to problem, particularly with fat suppression. Diffusion weighted imaging in breast MRI can improve specificity of a breast lesion by using ADC. In case of malignant lesion, ADC maybe less than 1.5 into 10 to the power minus 3 square millimeter per second, but it overlap. Spectroscopy in breast imaging may be done in single voxel technique or multivoxel technique. If it is done in multivoxel technique, it is referred to as spectroscopic or chemical shift imaging. It has the ability to keep the quantitative information of choline concentration, and we know that choline is synthesized by membrane synthesis. The more the membrane synthesis, the more the choline concentration will be, and so we can thus assume that either it is a malignant lesion or not a malignant lesion. And the accuracy of spectroscopy is increased by 3 Tesla machine. How we characterize lesions by MRI? So the approach is that we designate the morphology into either into benign section or in the malignant section, and this designation criteria is same as like mammography and ultrasonogram, such as in malignant lesion the lesions are poorly defined, irregular margin, and may show speculation or parenchymal deformity. And how we assess by enhancement? Malignant lesion has a rapid contrast uptake and followed by washout or plateau phase in the intermediate and late periods. Malignant lesion can also show ring enhancement, and dynamic contrast enhanced MRI is essential for detailed enhancement curves calculation. Though the enhancement kinetics has overlap in benign meningeal lesion, MRI can effectively exclude invasive cancer with a high degree of certainty if no enhancement is seen. And this enhancement kinetics is essential if it is a mass lesion, but if it is not a mass, if it is non-mass, then this enhancement of non-mass will be due to ductal cell carcinoma in situ or maybe due to lobular carcinoma. We can characterize lesion by using birates. So lesions characterized using birates into three morphological group. Number one, maybe the lesion is a focus if it is less than 5 millimeter, and then it is rarely worthy of further investigation of such a focus lesion. It may be a mass that is more than 5 millimeter, and maybe a non-mass enhancement. Non-mass enhancement is an area of enhancement without a morphological correlation. So what is the optimum time for lesion characterization by breast MRI? It is the second week of menstrual cycle, because in this period background glandular enhancement is least. So we can differentiate between malignant lesion more more conveniently in the second week, and this timing is not cannot be done in case of cancer staging patient, but it can be used for screening and follow-up studies. And what are the procedures that interfere with MRI? Recent surgery can interfere, radiotherapy can interfere, and we have to keep in mind that enhancement pattern return to normal between 3 and 6 months after radiotherapy, so it's a long time. And percutaneous breast imaging, breast biopsy such as FNAC core or vacuum assisted biopsy rarely interfere with MRI breast interpretation. So what are the indications of breast MRI? We do breast MRI for local staging of primary breast cancer because it is highly accurate for sizing, and it additionally can show multifocal unsuspected multifocal disease, and it may even show tumor foci in the contralateral breast. But we reserve breast MRI for such local staging of primary breast cancer for such patient where estimating tumor size is proving difficult by conventional method, such as if mammography cannot detect if the breast is mammographically dense, then we can use MRI for local staging. If there is significant discrepancy between size estimation at mammography, ultrasonogram and clinical examination, then we can use breast MRI for local staging. If the lobular primary carcinoma is there, then we can use MRI for local staging, because lobular carcinomas they are more multifocal compared with ductal no specific type tumors. Lobular carcinomas are difficult to detect. They are also difficult to measure size by conventional method due to their infiltrating growth pattern. Breast MRI also useful where occult primary tumor is present in women who present with malignant axillary lymphadenopathy. Breast MRI is also useful in post-surgical breast to differentiate surgical scarring and tumor recurrence. MRI can help to assess the response to treatment in women receiving neoadjuvant chemotherapy for locally advanced primary breast cancers. Neoadjuvant chemotherapy can also be used to downstage larger lesions, and MRI can be used to plan the extent of surgical resection in positive responders by neoadjuvant chemotherapy. We can plan the extent of surgical resection so that ultimately we can plan for a breast conserving surgery. MRI in screening can be done for the patient who has a high familial risk of breast cancer. But we have to keep in mind that screening with MRI is superior to mammography in detecting invasive breast cancer. It's true, but mammography remains more sensitive for detecting ductal cell carcinoma in situ. So, after finding a lesion by MRI, what we will do? We will use the principle of mammographic review and second look ultrasound. That means that we will review our mammography, we repeat the ultrasound. If we do not find corresponding ultrasound abnormality, then we can think of about MRI guided biopsy followed by histological diagnosis. Again, we can think follow up MRI. If the lesion is considered low risk, then we can think of MRI follow up, typically 1 year. So this is all for today. There are also scope to talk about controversies surrounding the use of breast MRI, and also about breast implant MRI. Maybe we will talk it later on. Thank you for listening.